Neil. Dr. Goodall, yesterday we had just looked at the data from the SITREP of the 30th of March. We're going to look now at the SITREP data from a week later, the 7th of April. But before we do that, could we have a look at the information that you were passing to the local health boards on that same day, the 4th of April 2020? Can we go to table 7 that's at page 171 in your witness statement, please? You explained that you wrote to the local health boards on the 4th of April to discuss their capacity plans and included this table at page 171 in your letter to them. This is in INQ 485721. There we are. So this sets out the All Wales requirement. 900 beds would be required in critical care, is that right? And 10,000 additional acute hospital beds.
Yes, that's correct. This was based on the work that SAGE had undertaken that we had been reviewing since early March. There had been some refinement of it, but we were using that methodology and just translating it into what that would mean for Wales based on the reasonable worst case figures.
And numbers have been allocated for each of the local health boards. Had these numbers come from the local health boards as to what they were going to be able to provide, or had this been sent out to the local health boards as these were their targets?
Yeah, health boards have been working on the ways in which they could expand their own capacity on a local basis, but this was very deliberately a national approach to say what we believe the numbers should be for planning purposes. The reasons for that was to just give support to our hospitals across Wales, to the clinical teams to know what their planning assumptions were, to prevent people spending too much time trying to do a whole range of local assessments. And because we were using the standardised methodology of SAGE at that time, it was very reasonable for us to direct that at an All Wales level. And it was to give clarity. You'll notice that there is one health board which wasn't allocated any beds. That's simply because of its particular function.
They don't have an acute hospital in Paris. But sorry if I haven't quite understood, but are you saying then that these were figures that were given to the local health boards rather than figures coming from the local health boards as to what they could achieve? Is that right?
Yes, these were planning figures that we set at a national level, right, which we wanted all health boards to give us plans and proposals for.
Thank you. So at that stage, 900 critical care beds were going to be needed in total. That's including the existing beds, is that right?
Yes, that's correct.
Thank you. So we've seen that that's changed somewhat from the figure in the TAC advice of the 15th of March when 1,650 ICU beds were projected to be needed. And we can see here that this says reasonable worst case scenario 40%. So is it that it was on a different modelling basis? Is that why the figures have changed from the 15th of March?
There had been some refinement of the SAGE model through March, and we were just using the latest version. I think this was based on version 2.3 at the time. You'll recall that the early March modelling was talking about a figure of around 1,500 critical care beds, and this was reflecting a reduction in that. But the 40% reasonable worst case figure that we were using was based on an assumption of 40% compliance of the population with control measures. It was expecting a conversion to hospital beds of patients needing hospital beds of around 4.4%. And at that time, there was an understanding and expectation that about 30% of patients who were hospitalised would require critical care. Obviously, those assumptions changed over time as we learned more about the virus, but they were the SAGE modelling assumptions at the time.
Okay. The inquiry heard from Public Health Wales that 40% reasonable worst case scenario did not mean 40% compliance or 40% of the population complying with non-pharmaceutical interventions. It meant 40% of the reasonable worst case scenario. Do you know which is correct? Which interpretation of 40% reasonable worst case scenario?
figures were introduced here, and my statement is clear on this. These were based on the 40% compliance with the control measures, and that's referred to in my statement.
Thank you. Can we have a look then, please, at the data that you collected from the local health boards on the 4th of April? This is shown at page 167 of your witness statement. And there are some changes from in terms of the categories of data that are collected here compared to what we saw yesterday from the 30th of March 2020. So we can see that the data collected here is invasive ventilated beds is split into in a critical care environment, in a hospital but outside of a critical care environment, and temporary beds providing invasive ventilation outside of a hospital building. And the total invasive ventilated beds have gone up somewhat to 356 beds. But if we can look at the box below that, we now see the total number of designated COVID-19 hospital beds, non-designated COVID-19 hospital beds, and total hospital beds, which is 6,786. Temporary beds providing hospital care outside of a hospital building, and total other, it says brackets, non-invasive ventilated beds. So that seems to be beds that do not provide invasive ventilation rather than beds that are providing non-invasive ventilation. Is that correct?
That's correct.
So we don't see here any beds that are providing non-invasive ventilation, and we don't see here beds that are providing CPAP, which we did have on the 30th of March. Why have those categories been removed when they were there the week before?
I'm not sure why they were removed, whether this was just an aggregate that we were able to pull together. I would assume that the data was still being reported underneath. But I think there was a particular focus on the intensive ventilated bed capacity that was required. We were still able to track and did introduce later ways in which we understood where patients receiving ventilation were outside of the critical care environment. But I would need to check. I can't recall from my statement that is explaining why that was the situation.
I don't think it's set out in your witness statement, Dr. Goodall. We heard from the medical director of NHS England last week about why categories of data were collected and the type of data that was collected in relation to hospital beds. And the approach in England was less to do with the physical location of the bed and more to do with the clinical capabilities of the bed and the kind of support that could be given. So whether it was staffed, whether it had equipment and consumables, the staffing ratios that would designate that either as a level 2 or level 3 critical care bed, whether it had oxygen capability, whether that was high or low flow oxygen capability. But that data doesn't seem to be collected here. Did that change at any point, or was this as granular as the data got?
The data was changing as we continued responding to the pandemic. So, for example, later on in April, we saw further changes where we were able to bring in the field hospital data. Because during March we had been assessing the numbers of ventilators, non-invasive ventilators. We'd been tracking oxygen support, for example, rather than have separate submissions. We were able to draw those into the SITREP reports as well, as we had that more broad view of things that were happening on the ground and that were helpful to us to understand at a national level.
All right, but certainly at this point on the 4th of April, that level of data isn't being collected. We can see that surge capacity is shown here, but already in the total invasive ventilated beds, which isn't in the surge capacity section, 356 beds, that is the expanded number of beds, isn't it? That's not the baseline, how many you started with.
That is the number that we were planning that we could expand to, given the requirement for 900 and what had been 1,500. As I explained yesterday, it was always really important to set that in the context of what was the normal critical care capacity that was available in Wales, and that was 152.
But that doesn't appear on this table, does it? It doesn't show the original number of beds as 152. So it doesn't differentiate, does it, even between beds that are functional and ready for use and beds that are theoretical, in that they exist but they're not necessarily staffed or with an oxygen supply, for example?
Indeed, we would know those number of beds within the Health Board's own reports. They would understand their baseline levels as well. But as the performer moved, we did introduce that. And also I was very clear in the personal updates that I chose to give from a very early stage of the pandemic. These weren't the official SITREP reports, but it was me giving a sense of how the NHS was responding. I was always very clear in those reports to refer to the baseline for critical care beds, for example, so that ministers would understand actually that stretch on the system and the pressures that were being experienced across the hospital.
Is it right that it was the minister, in fact, who asked to have that information included, wanted to know the baseline and how much over baseline it was? Is that right?
Yeah, the minister was aware of those numbers from previous involvement when we were expanding critical care beds in Wales before the pandemic. He was also aware, because I was reporting on that to him in my own more personal reports that were being submitted as well. And he felt that was a helpful addition, just to make it very clear to wider colleagues as well, beyond just himself and the First Minister, of course.
Can we stick with this table then and what's shown on this table? Who is this table for?
This table was being reported in to us to have a national summary. It was underpinned by local hospitals.
But
it
who
allowed
is it
us to have a
for?
sense of. It was
Who's
us
supposed to be looking at this?
Yeah, this was for us in NHS Wales, but it also satisfied the reporting that was able to feed up to ministers to have an understanding of the performance of the NHS across Wales.
So it's not clear at a glance from this which beds are ready to be used, which beds are in surge capacity, which beds are purely theoretical, how many patients are receiving CPAP, how many additional beds are available for patients who need mechanical ventilation. None of that information is immediately apparent looking at this, is it?
It's not immediately apparent from this, but we would have expected that health boards would have their own understanding when they were submitting this information. And in terms of the immediately available beds, they would be represented by the totals that were on the left-hand side in terms of the total numbers that are available. The additional capacity available within 24 hours, 24 to 7 days, and after 7 days, they were reflecting that they were beds that we could step up into based on need, if they needed to be commissioned by the local health boards, and that was the national picture on those.
All right. Can we have a look at the way the local health boards were dealing with the data that was being collected and their access to that data? You've been provided with the witness statement from the Chief Information Officer from Cymtath Morgannwg Health Board. I don't think we need to go to that witness statement itself. It's INQ 0004095575. And the Chief Information Officer is quite critical of the limitations on the data that was collected by the Welsh Government, particularly in relation to CPAP. He says this: the recording of CPAP use was never resolved in Wales. As a result, the SITREP reports were never relied upon anybody undertaking analysis. Rather than addressing the shortcomings, the publishers presented the numbers with a warning on that they included suspected numbers. The absence of reliable CPAP data meant that we went through the first and second waves unable to evidence our preparations as to whether we had enough CPAP machines and oxygen to meet need. The lack of data diminished the ability of clinicians to use data to audit and compare the effectiveness of care for COVID patients. Better data would potentially have helped care optimisation or have helped the clinical team to make changes to how they delivered care earlier. Dr. Goodall, do you think those are valid criticisms of the data collection by the Welsh Government?
I think they are valid criticisms of the data in terms of the summary and aggregate reports that we had. There were other ways in which we could access that information. So, for example, the references that Mr. Nelson has made to oxygen and CPAP, we were assessing those through the planning and response structures and able to draw on those. And actually, after the oxygen assessments that have been undertaken, given that they had been escalated by the NHS Wales and we were involved in supporting the plans for those, we were able to maintain a group that was overseeing those oxygen arrangements that had a particular focus around our estate's infrastructure as well. So whilst the summary and aggregate information may have frustrated some of the understanding, there were other sources of data that were available that we were able to pull in from those operational experiences within the NHS in Wales as well.
But what about the point that's made that it was hampering the ability of clinicians to assess what was the most effective form of clinical support for COVID patients? Data wasn't just for use by the Welsh Government in terms of counting how many beds were there. Data has a number of important uses, doesn't it, during a pandemic?
Data has many important uses, and certainly from a Welsh Government perspective and reporting into the Health and Social Services Group, we wanted to make sure that we had a subset of data that was helpful to us at a national level, which we were able to collect routinely and without inappropriate impact on the system. All of the operational data that is normally in use by the NHS in Wales was still available in terms of that local use. What was helpful to us was the way in which our clinical networks in particular were able to step into some of the understanding of this data. So, for example, through our National Respiratory Lead or through our critical care network, we were able to make sure that there was a more refined understanding of some of that data. And again, there was a way in which that could be fed into us as well.
Can we have a look at the pressures on the system in terms of critical care occupancy during the pandemic, please? And can we have a look at a graph that's been prepared, I think, by the Welsh Government? This is on page 182 of your witness statement. It's figure 7. And it shows, I think, weekly patients in invasive ventilated beds. And we can see there that the black line shows confirmed COVID patients, the brown line suspected COVID patients. Is there any reason why confirmed and suspected COVID patients have been split up in this data? Would they not be cared for in the same facilities?
Yes, they were cared for in the same facilities, but it was just allowing us to understand that for some patients there was a time lag, even if it was short, about having confirmation of their test, but they were being treated as if they were COVID patients. On occasion, you may end up with a patient who was suspected to be COVID, where the test result did not confirm that, yet they still needed to have access in critical care, of course. But it just allowed us to understand some differences around the data. So confirmed was really the core actual position. It allowed us to understand the surveillance of the virus, if I could put it in that way.
Well, I'll if I can stop you there. Can we have a look at what we're seeing on the graph? This has split up non-COVID and COVID patients. So the number in invasive ventilated beds would be the combined number, I think. These are numbers rather than percentages. Did the Welsh Government ever have data on the percentage of available beds in intensive care that were occupied, whether by COVID or non-COVID patients?
Yes, because we had the data, we were able to track the percentages as well.
And did you have that information by hospital and local health board to show where there was pressure on capacity in particular places?
Yes, we did. The aggregated summaries you showed earlier were all supported by individual health board and hospital positions.
All right. Can we have a look, please, at your witness statement at page 183? This is paragraph 455. The final the final sentence there says, in terms of whether critical care capacity or general bed capacity was reached or exceeded in any local health board or individual hospital, Digital Health Care and Wales will be best placed to confirm this information. Why does the Welsh Government not have that information?
We had it at the time as we were going through the pandemic and receiving it on the spreadsheets and the databases. I think that's just a practical data issue for DHCW to provide it based on holding all of the information throughout the whole period of the pandemic. They have it accessible on their database.
Sorry, does that mean that you had it at the time, but you don't have it anymore?
Yes, that's correct.
Why is it that the Welsh Government hasn't retained that data?
I don't know why that is the case in terms of responding to the inquiry. I would have to check outside, I'm afraid, with colleagues supporting me. But we did have it at the time because I was looking to help at the individual information for hospitals, for example, from those spreadsheets and the way in which the information fed through.
Do you know how long it was kept for, or at what point that data was disposed of?
I'm sorry, I can't comment on that. I would have to check with the team supporting the responses to the inquiry, I'm afraid. I'm very happy to do that, of course, from today.
All right, perhaps we can move on to CritCon levels, because that was another way of tracking capacity and the pressures on capacity in critical care. Is it right that CritCon levels were recorded on the unscheduled care dashboard for Welsh Government data only from December of 2020? Is that correct?
Yes, that's correct.
How was Welsh Government then collecting information on the pressure in critical care prior to December of 2020? Why was it not recorded until then?
We were receiving the daily updates that allowed us to track in data terms the pressures on the system. At the same time, we were able to link regularly, usually daily, on occasion through the day, with the critical care network that was made up of our frontline clinicians. There is a national clinical lead for critical care as well, and a team supporting them. And they were also involved in supporting us with some of the operational requirements of the system in Wales. They're not an operational unit themselves, but during the pandemic, they really helped to make sure that there was a more direct understanding of the pressures that were being experienced across critical care. But we felt that the inclusion of CritCon from December, particularly as we were moving through the second wave and with the pressures that the NHS experienced, were a further helpful way of understanding those pressures across Wales.
Would you accept the recommendation that was made by Stephen Matthew of the Intensive Care Society that it would be beneficial for CritCon to be used across Wales in future pandemics or at times of extreme, for example, winter surge pressures?
Yes, I would agree with that. One of the reasons it works very well in England is an issue of scale because of the coverage of the very many critical care units. Because we have smaller units in Wales and with the critical care network, they do liaise with each other very frequently. But I do agree that having the CritCon status available, again, just provides another level of information beyond the data.
You touched on the fact that the Wales Critical Care and Trauma Network is not an operational network, so it's not a critical care transfer network in that sense. Were the Welsh Government informed if local health boards had to transfer critical care patients out to another hospital or local health board during the pandemic?
Mostly, if that was happening, that would be an operational issue in respect of mutual aid and support happening between individual health boards and indeed individual hospitals. There were escalation mechanisms available, daily bed calls, the critical care network itself was meeting, and often they would be brokered through that. They were not happening very regularly, but they would tend to be held at that more operational level within the health boards themselves.
So is the answer to that no? The Welsh Government were not informed if local health boards had to rely on mutual aid?
We were not informed as part of the process, but we would often have team members from the Health and Social Services group who would be sat on those calls. But the answer would be no in terms of the operational pressures.
So is it right that the Welsh Government didn't ask the local health boards to keep them informed of whether they were having to rely on mutual aid from neighbouring local health boards? Would that not have been a useful piece of information to have had?
It would have been a useful piece of data and information to have. Often those types of experiences were reflected in the chief executive calls or with the medical director calls, and we would have a sense of the way in which, certainly in the first wave, the virus was spreading across South Wales. But that would be useful information to receive, I agree.
Finally, in terms of numerical data that was collected by the Welsh Government during the pandemic, do you think that the Welsh Government were collecting sufficient data at the right level of granularity during the pandemic? Do you think this is an area where the Welsh Government could have done better?
We were, in the very early stages, trying to ensure that we could draw on appropriate data that was in use by our local hospitals and by our local health boards across Wales, and indeed some of the other sectors. I do agree that the pandemic has given us learning about the level of detail that is useful to use, which doesn't provide a burden or pressure on the system, but really brings to life the experiences across the system. I think the data doesn't just tell you the experience, even though we can track and see how things are changing even day to day. It's really important that you build in wider experiences as well. And it was why it was so important to have other ways of talking to our hospitals, to our frontline clinicians, to our executive teams, to make sure that we had a genuine understanding of the pressures that they were experiencing, that their staff were experiencing as well. And I think we enabled that through national calls, through our clinical networks in Wales, to try and, I hope, bring that more to the surface than just the data itself.
Could I ask you, please, I think you've been provided with the evidence of Professor Fong, who explained to the inquiry that he was involved in a scheme of peer support visits to intensive care units to see really the reality on the front line, going beyond the numerical data to the experiences of staff in very pressured intensive care units. Professor Fong explained that he had received requests from other nations to carry out similar visits, but he said he wasn't aware of any similar scheme taking place in other nations. Were you aware of any requests for peer support visits coming from any hospitals in Wales where they wanted a scheme like Professor Fong's?
I'm not aware directly of a request for a similar scheme. We were receiving advice from our clinical networks, and in this respect, particularly the critical care network, but often that was a way of hearing that voice very directly anyway, but I'm not aware of any requests for a similar scheme, given that I've obviously had the opportunity to read and seek Professor Fong's evidence. In
the event of a future pandemic, would you see the benefit of a scheme like that in Wales?
I would absolutely. I thought it was very powerful evidence, and I do believe that would definitely help us to have even more of that frontline experience demonstrated to us and be able to use it in that very effective way.
Right. So moving on from data now, can we look briefly at the steps that were taken by the Welsh Government to maximise existing capacity in the NHS in Wales? I think it's correct that on the 13th of March, the Minister for Health and Social Services published a ministerial statement setting out a framework of actions for the healthcare system in Wales. Can we have a look, please, at that ministerial statement? And if we can look at the first 4 of those bullet points, please. Can we look at the numbered points? Thank you. So this was where the local health boards were being advised to suspend non-urgent outpatient appointments and ensure urgent appointments are prioritised, suspend non-urgent surgical admissions and procedures whilst ensuring access for emergency and urgent surgery, prioritise use of non-emergency patient transport services to focus on hospital discharge and emergency response, and expedite discharge of vulnerable patients from acute and community hospitals. I think it's right that that wasn't a ministerial direction, so there was discretion for the local health boards as to how they were going to implement this framework. Is that correct?
That's correct. They had the opportunity to implement this at a local level, and these issues emerged from a range of discussions with senior leaders in the NHS in Wales, medical directors, about the types of actions that would genuinely help them to prepare. So rather than just decide these nationally, these really emerged over the course of the previous few days, and in fact were set out in some correspondence that we received collectively from chief executives and also from medical directors in Wales.
All right. Now, after this framework of actions was issued on the 13th of March, which effectively were suspending elective treatment, can you help us? Was there any guidance or instruction from the Welsh Government about restarting elective surgeries? And if so, when was that made?
So that happened later as we had come through the first wave and had seen the peak and were starting to see the opportunity to focus on other activities in the NHS. We formally set these out in terms of requests within quarterly operating frameworks that we used. And that's where we asked, although it was done in a cautious manner, that there were opportunities to start to recover some of our activities. In the first wave, in practical terms, our planning horizon was having to work 2 or 3 weeks ahead only. So the introduction of those quarterly frameworks were really important to give that wider guidance to the system and track it alongside the concerns and worries about the virus as well. I should explain that these operating frameworks were usually discharged over a 3-year period, so this was quite a change in our outlook for planning.
If we can focus, please, on elective care in Wales and when that was resumed. The inquiry's heard from 2 experts in orthopaedic surgery, Professor Metcalfe and Ms Chloe Scott, and I think a transcript of their evidence has been provided to you. But they've explained that multiple figures showed that the delivery of restoration of elective care in Wales was significantly delayed compared to that of England. And Professor Metcalfe told the inquiry that meetings were first held about recovery of elective orthopaedic care in Wales in 2021, and the first guidance document was released in 2022. And he made some criticisms of the guidance document, saying that it's more vague than the NHS England guidance, and it's not linked to any financial incentives for local health boards. And as a result, treatment delays in Wales, in the words of Professor Metcalfe, were absolutely huge. Do you think that the Welsh Government should have planned to recover elective care sooner in the pandemic and taken steps to incentivise local health boards to restore those elective services?
Looking back now where we are, I think we should have done that earlier than we did. We did give permission for the instigation of routine activity, including in our first operating framework in May 2020, but that was absolutely in recognition of the environment we were in at the time. They were operational matters for health boards to take forward. Whilst the Orthopaedic Summit took place in 2021, other guidance had been given in those operating frameworks for actually taking the opportunity to restore guidance as well.
In terms of practical steps that could be taken, can I ask you this? The inquiry's heard a recommendation from those 2 orthopaedic care experts, and also in relation to cancer care, colorectal cancer care, about the use of hubs, elective hubs, which would provide elective surgeries on a separate site away from urgent and emergency care. Is that a recommendation that could practically be implemented in Wales, or are there barriers to doing that?
Yes, that's a recommendation that can be implemented, and we did have hub set up within individual hospital sites as well. There is a need for an understanding of the way in which that would mean that services would be changing across different areas of Wales. And when we are normally working through these sorts of choices, there are consultation processes, for example, not least with communities, about understanding those change of services. So it's just about recognising that there are consultation and engagement mechanisms that we need to do. But obviously within a pandemic, there are different ways in which you can respond to that more in an emergency mode.
All right, thank you. Perhaps we can move on now to following on from the framework of actions which was published on the 13th of March, as well as expediting discharge. I think the Welsh Government also produced some guidance on admission to secondary care. and published on the 23rd of March 2020, the COVID-19 Primary and Community Care Guideline. And can we look very briefly at this, please? It's 226967. Thank you. On page 7, please, there is a flowchart. This is for primary care practitioners. To go through this flowchart as to whether to admit a patient. And there are a series of questions there. Does your patient meet criteria for respiratory distress? Does the patient have an advanced future care plan that applies in this case? Is the patient likely to benefit from ICU escalation? Yes, they're admitted to acute hospital. No, discuss admission with the front door clinician. And there's an asterisk at ICU escalation, and it says evidence shows that the following groups do not respond well to ICU escalation. Clinical frailty score of 5 or above. And if we can have a look quickly, please, at I think page 16 shows the clinical frailty scale there. 5 is mildly frail. Is it right that the purpose of the Welsh Government in publishing this guidance and this flowchart was to try to minimise the number of COVID patients being admitted to hospital by general practitioners?
It was to try and support the overall preparation, but also to try to push patients to the right level of service that needed to be available. And this guidance had been developed by our primary and community response group, which included a wide variety of representatives from all of our health organisations in Wales, and was led by clinical leaders as well.
Thank you. So the guidance was published, this guidance was published on the 23rd of March 2020, and a little over 2 weeks later, on the 8th of April, it was updated, according to your witness statement, to include guidance that the clinical frailty scale should not be used in younger people, people with stable long-term disabilities, such as cerebral palsy, learning disabilities or autism. Now, the inquiry has heard from Dr. Paul Crisp of NICE that the guidelines for critical care for COVID patients that have been published on the 20th of March 2020 were amended on the 25th of March to make that amendment about the clinical frailty scale not being appropriate for younger patients with long-term conditions, as I've just set out. Can you explain why it is that after those amendments were made to the NICE guidelines to clarify that it was not appropriate to apply the clinical frailty scale to younger people, why it took until the 8th of April for the Welsh Government to make similar amendments to this admission criteria?
I can't respond to why that delay would have been there. I would just be speculating, but I would have thought that the planning and response group would have been taking a look at it again, but I won't be able to respond to the specific question, I'm sorry.
All right. Perhaps we can move on to increasing capacity in terms of the medical equipment and supplies that were going to be needed by the NHS in Wales. And I think there were some concerns initially in relation to items that were going to have to be sourced on a 4 nations basis. And can we have a look, please, at INQ 479929? This is an email from you on the 27th of March to Vaughan Gething, who was then the Minister for Health and Social Services. And this is raising issues about supply arrangements for the UK. And we can see some of the concerns that you had at this point of time. So you set out that there are some concerns because of the way that testing and testing kits were being supplied to Wales, that you were concerned that there may be some similar supply arrangement problems with Wales not getting equitable access to either tests, or PPE, or ventilators. And can we see there at point 3, speaking to other devolved governments, the supply process is feeling that we're excluded from the UK NHS England arrangements. We're not cited on work streams at any level of detail, and this is affecting our ability to plan. And then going on. It says there's an emerging discussion about how supplies, whether ventilators, PPE or others, will start to be distributed to an assessment of need rather than equity. The concerns for this is that in planning terms it will create concerns for Wales about resilience and business continuity. So your concerns seem to be at that point that effectively if the wave hit England first, their need would be greater and all those finite resources would have been used up by the time Wales needed to draw upon them. Would that summarise what your concerns were at that point?
Yes, they were genuine concerns and it was a very fast-moving picture. But yes, there were early signs of planning for England having an impact on some of our supply lines in Wales, and we were just looking to make sure that that didn't happen in practice.
Can I ask, did that happen in practice? Did those concerns materialise?
It didn't happen in practice. I was really pleased with the way in which colleagues responded. I think there was possibly some clumsiness on some of the instructions that were provided. So, for example, when liaising on areas like PPE, NHS England was being used as the criteria rather than the NHS more generally, and this is why it affected colleagues in Scotland and Northern Ireland as well. But when we were able to escalate and talk to our colleagues through our structures, at times I did that personally myself, there was always a very appropriate response and we were able to ensure that that settled down. But at this time, we were seeing very significant pressures in London, for example. They were a few weeks ahead of the first wave than the Welsh position. And you could just see how there was the potential for resources to be drawn to those starting points for the virus in the United Kingdom.
All right. So looking then at ventilators, I think you've set out in your witness statement that at the start of the pandemic, NHS Wales had 415 invasive ventilation machines, 207 non-invasive ventilation machines, and in 2020, 1,238 further ventilators were procured by NHS Wales and also through UK arrangements with the Department for Health and Social Care. At that point when additional ventilators were in the process of being procured or supplied, were any steps taken by the Welsh Government to ascertain whether there would be sufficient numbers of staff trained to operate those additional ventilators?
In the first wave, we were working through where it was really important to make sure that we had the physical capacity and then we had the equipment capacity. The workforce plans were always being progressed and working through. Just because we were planning at that point for 1,500 ventilators did not mean, of course, that there would be 1,500 staff available to support those 1,500 ventilators. That would be something that we would have to continue to progress, introduce the training and introduce the skills. But we were always starting with making sure that the physical requirements were in place first.
And did the Welsh Government take any steps to ensure that there were enough trained staff to operate that additional number of ventilators?
Not to that number at the outset, but we were introducing additional training. Health boards had reduced plans. They were redeploying staff. There was both local training available. We were also escalating training through the critical care network as well. That was making sure that we were able to grow the number of staff who were available. But we were at that point well short of any ability to manage 1,500 ventilators if that situation had happened in practice.
All right, thank you. Now, plainly, increased use of ventilators in hospitals is going to require an oxygen supply, sufficient oxygen supply. And I think it's right that Welsh Government worked with NHS Wales and the British Oxygen Company and the Royal Engineers to try to expand existing oxygen capacity in the NHS estate. And by June 2020, I think the Royal Engineers produced a report which indicated that a 75% increase in oxygen provision had been achieved. Was that sufficient to meet the likely or the projected increase in demand for oxygen?
If we were still moving to some of the modelling levels, which could still be at extreme, that level still would not have allowed us to achieve it. But at the time in June, it was felt to be an appropriate recovery of the oxygen facilities. And we had some physical developments in our estates as well. So we'd been able to access oxygen for field hospital facilities where that was needed and necessary. But if we had continued to see the modelled position right through 2020 and into 2021, that would have continued to stretch our oxygen capacity. Having said that, we were in liaison with British Oxygen. We had clear recommendations, and we had a group that was working that through with the local health boards in Wales very regularly as well. So we were always continuing to progress that position.
All right. Now, can we move on, please? You touched there on field hospitals. Can we look at field hospital provision in Wales and the role of the Welsh Government in relation to field hospitals? I think it's right that the Welsh Government provided funding for field hospitals. And you've set out in your witness statement initially £166 million was allocated to local health boards for field hospitals. In 2020 to 2021, capital funding of £50 million was provided for field hospitals, in addition to £10 million for the early opening of the Grange Hospital in Aneurin University Health Board. £83 million was also spent on works across the estate, some of which would have been spent on field hospitals. So having allocated £166 million initially, can you assist us with the total, the final Welsh Government spend on field hospitals during the pandemic? I can take you to paragraph 521 of your witness statement, if you like, which contains those figures, but there aren't any other figures that have been provided. Was that the final spend?
Yeah, the formal cost, that was the final spend. I mean, you're right that in respect of some of the enabling estates work, we were unable to set out the specifics that were for field hospitals themselves. So the revenue costs as set out in that table were for 136 million, but there were those additional capital costs that we used as well.
And in terms of the number of patients admitted to field hospitals during the pandemic, if we can go to page 200, we're on page 206, please, of your witness statement, paragraph 514. You say that in terms of numerical data of how many patients were admitted to field hospitals for the relevant period, the Welsh Government did not request this data from the health boards, as distinct from the admission data. That's the information we saw before about how many beds were occupied and so on. Why did the Welsh Government not request data from the local health boards about how many of the beds that have been created in field hospitals have been utilised?
Within the separate reports, the category that you were showing earlier was allowing us to report on patients who were outside of the normal hospital facilities. So we were able to track the data very generally in there, but it was very minimal data because of the change and the mitigating factors, the lockdown that occurred, we ended up not needing to use the field hospitals as intended, of course. So there was a real change on it. But it was set up within the SITREP report. In respect of an understanding of how the local health boards were using it, we did undertake reviews at various points drawing in that experience. And there was a group available in Wales that was also tracking it as well. But I think it would have been the SITREP data field that would have allowed us to understand it. But there were very minimal numbers in there, as I was just saying, because we simply didn't use the field hospitals as intended. They were a contingency preparation, and unfortunately, they did not need to be used in the way that was intended.
Can we look at some concerns that were brought to your attention by some of the local health boards about the resources that were going into field hospitals? Can we see, please, INQ 000474458? This is an email from a local health board, Cardiff and Vale local health board, to the Deputy Chief Medical Officer. He says, if we can go to page 2, please. I feel I need to send this email just to relate what I see on the ground in Cardiff at least. I don't have access to the NHS Wales information service data on capacity elsewhere. So the local health boards didn't have information, is that right, about what was going on in other local health boards or nationally across Wales? They didn't have access to that data?
I would assume that they would have had access to the data. We were always sharing it and discussing it in the meetings that were happening at that time. But from a SITREP perspective, their focus would have been on the submission of their local data.
But it seems that the writer of this email is saying that he doesn't have access to information about what's going on in terms of other local health boards and their capacity. But he goes on to talk about what's happening within his health board. And he says, I write this because I'm concerned about the huge amount of resources going into Dragon's Heart. My prediction is that this will be an enormous white elephant. I fully understand that Welsh Government need to prepare for worst-case scenarios, but I question whether this is necessary, given what is happening on the ground. And he says that there is huge capacity in the system, at least in relation to that health board. Were you aware of those kind of concerns? Did the Deputy Chief Medical Officer speak to you about any of this in terms of the amount of resources that were being diverted from local hospitals into field hospitals?
I can't remember if the Deputy Chief Medical Officer spoke to me directly on that day. I would typically expect it because we were all with each other on a daily basis and we were having these very open conversations. The context of this time, of course, was that we had built up these plans on the modelling and had been working on those through March. We were still very much in the first wave at this stage. Even it was still 6 days after this that the peak of critical care capacity that we reached in the pandemic was hit. But I do agree with Simon in his note here that we were actually seeing a very big impact on our available capacity from the steps that had been taken on the 13th of March. So
right.
I, at this point, was doing press conferences and I was reporting on the available capacity
right.
for the NHS in Wales.
If we can focus then on what was happening in field hospitals, and I think it's right that the model of care for field hospitals was to provide step-down care rather than intensive care facilities. Is that correct?
Yes, that's the way the model worked in Wales. That's correct.
All right. So this was for patients who no longer needed acute care but weren't well enough to go home. Is that right?
Yes, that's correct.
Yes. And also to provide palliative care for patients with a ceiling of treatment. Is that correct?
That's correct.
So can I ask you this? Given that the projections from the 4th of April were for 900 intensive care beds or critical care beds, and by that date we know that 356 beds had been created with surge capacity within hospitals, although they may not have been staffed at that point, it was looking at that point as though Wales was not going to be able to create 900 additional critical care beds. In that case, why is it that no critical care beds were to be created in field hospitals?
It was the clinical model that was determined for Wales. It reflected the way in which the health boards wanted to use their local capacity. What they were looking to do was to make sure that they were able to expand their critical care capacity on their individual acute hospital sites, and that they would be able to decant or displace other patients into those other peripheral beds, which may at a moment have become the use of the field hospitals as well. So it was an attempt. Secondly, from a geographical perspective, and just a reflection of our rurality to some extent, we needed to have a distribution of those beds that was available across Wales. And that's why that model was used as a very local model as well. But it was to expand the capacity on the acute hospital sites for critical care and then to manoeuvre other beds into other areas.
But they weren't for... All right. Were the palliative beds for patients with a ceiling of treatment, were those beds for patients who could not be admitted to intensive care in the event that full capacity had been reached? Was that the thinking at that time? We're not going to be able to create as many intensive care beds as the projected as the modelling is telling us we're going to need. We're not going to be able to create 900 beds. We're going to have some sort of palliative care facility for people who if intensive care is full, they're going to have to go to a field hospital for palliative care.
I don't directly recall that being the intention, because it was intended to bring patients who had gone through their experience in the hospital and were to move to another facility. It was possible that it could provide some of that support if necessary. It would really just be a question of the pressures that we were experiencing and having the flexibility to use our capacity for those different purposes.
All right. So if we can move on past the first wave then, and the way that field hospitals were used there, it appears from a briefing provided to the Minister on the 26th of November that only 2 field hospitals were used during the first wave, and 46 and 34 patients were admitted respectively. Where was that information coming from if Welsh Government weren't collecting data on the use of field hospitals?
We had information in that SITREP line which talked about other hospitals, but also the teams were just always in contact with the individual health boards and with clinical teams in Wales. That's just the way we work on a normal basis, and we would have been using those relationships to describe that as well. There was also a group in place that was overseeing and supporting field hospital provision across Wales, partly a peer support mechanism, and Health and Social Service Group officials were also part of that group as well.
So do you know whether any of the field hospitals were utilised in the second wave, whether any patients were admitted in the second wave?
There were. So we were very fortunate that field hospitals didn't need to be used. They were ultimately there as a contingency based on the modelling. Having established them, we wanted to use as much as possible those that were remaining for alternative purposes. So there were field hospitals that we used for some patients when we received the peak in the second wave. That was in January 2021 and through that period of time. But there were also alternative ways in which the field hospitals started to be used, including use for vaccination centres.
If we can focus on their use as field hospitals for now, because I think the Minister on the 26th of November was being informed that 3 of 10 remaining field hospitals were operational at that point in November.
Yes.
You don't think they were used at all in the second wave, is that right?
There were 3 field hospitals that were operational, but during the second wave, which took us into 2021, there were some of those small numbers of field hospitals that were used and they were available. Again, as we went into the second wave, they were a contingency preparation for us to have capacity that we could expand into. So they were still discharging their original role and intention. But we had reduced the number of field hospitals from 19 to 10 by the time we got to November 2020.
All right. I think the 3 field hospitals that were operational at that point were Deeside in Betsy Cadwallader University Health Board, Seren in Cymtath, and the Grange University Hospital, which wasn't technically a field hospital. And I think you've been provided with a Healthcare Inspectorate Wales report dated the 19th of March 2021 into concerns about quality of care provided at the Deeside Field Hospital. So that appears that was being used in the second wave. Would that be correct?
Yes, that was one of the field hospitals that was in operational use at that time, yes.
All right. And that report identified a number of failings, including problems with IPC measures at that field hospital, a lack of individualised end-of-life care planning, and failure to use the end-of-life care pathway. Can I ask you this? Had you been made aware of those concerns about the quality of care being provided in that field hospital prior to the Healthcare Inspectorate Wales report?
I hadn't been advised of it before it, but I was obviously aware when Health Inspectorate Wales did their visit.
So those concerns hadn't come through any of the groups that you've just mentioned that were set up within the Health and Social Services group? That information wasn't filtering through?
Nor had they come through the health board itself, no.
No. Did the Welsh Government have any way of monitoring the quality of care provided at field hospitals?
We were in contact with all of the health boards on their plans and proposals. We had our professional networks in place. So nurse directors would be able to speak with the chief nursing officer and oversee those arrangements. We weren't doing our own assurance visits. We were very much leaving those legal and operational responsibilities to the health boards at the time. The regulator's role, Health Inspectorate Wales, is one of those ways in which we're able to get that more independent voice and to allow us to understand that from a national level, as well as, of course, the direct actions needed to be taken by the health board.
Did the Welsh Government undertake any review of the field hospital programme in order to evaluate what worked and what didn't?
There were 2 points in particular where reviews were undertaken. There was one in June 2020, which was an early review of the way in which the facilities had been established and the issues that had been faced. As I said, there was a group available.
What was the nature of that review, please? Was that an Audit Wales review, or what was the body?
An Audit Wales review. That was actually done by the Health and Social Services Group, working with a field hospital group in Wales in order to review it. And there was a similar review done on a similar basis. I think it was in March 2021 as well.
So June 2020 and March 2021, but nothing at the end of the programme?
No, you would have to speak to Judith about how she picked up issues after the end of the programme, after the pandemic was finished, after October 2021. But I don't recall anything. There were learning reports that were produced, I know, because of the interest in field hospitals and how they'd been established and how staff worked together, but they weren't directly commissioned by Welsh Government.
Perhaps we can move on and look at the use of private hospitals for NHS care during the pandemic. I think, again, this was funded by the Welsh Government. £30 million of funding was agreed on the 25th of March 2020 for the commissioning of additional capacity from the independent sector. Is it correct that that total capacity was 152 beds, some of which were day case beds, in 6 inpatient hospitals across Wales? I think it's right that there weren't any intensive care beds provided in private hospitals. Is that right?
Yes, that's correct, and your point on critical care capacity is correct as well.
Did the Welsh Government collect data on how much activity was performed under those contracts that it had funded?
The contracts were overseen by the Welsh Health Specialised Services Committee. That was acting on behalf of the local health boards.
Did you collect data on how much activity was performed?
The tracking and monitoring was done through that mechanism, wasn't necessarily done through Welsh Government at that time. It was an operational matter for the health organisations.
Did you have data on do you know how many operations or other activities, outpatient performance appointments were delivered through independent providers for NHS patients?
Yeah, we had reports from the Welsh Health Specialised Services Committee, but they were not part of our daily SITREP data.
No, I didn't ask whether they were part of your daily... Perhaps we can go to page 218 of your witness statement, paragraph 545. If we can get up page 218, please. Thank you. You say daily SITREPs on activity were developed on behalf of NHS organisations for monitoring purposes and to ensure maximum usage of the capacity available. This information was not produced by or held by the Welsh Government, as it was not party to the contract arrangements. Does that mean that you didn't have that information?
It means that we would receive the information when officials were liaising with the Welsh Health Services Committee, but we were not formally part of the contract review and monitoring information, so we could have it available, we could be provided with it, but we weren't formally monitoring the contracts.
Do you know how much activity was performed under those contracts when the contracts ended? Would you be able to give us...
I can't recall where in my statement I set out those numbers, but we have information available that was provided to us by the Welsh Health Specialist Services Committee that would tell us what those numbers were, and we were reporting it internally in order to have an understanding from various occasions within our Health and Social Services Group arrangements and also with the NHS Leadership Board as well.
I don't think there is anywhere in your witness statement where you set out those figures, but they are available to the Welsh Government, are they?
They will. I'm very happy to report back on those figures that we have available.
All right. Can we turn, please, to some PPE issues in healthcare settings and in hospitals? You've explained in your witness statement that there was a PPE pandemic influenza stockpile that was held in Wales, and at the beginning of the pandemic that was utilised until the pandemic arrangements were completed with the Department for Health and Social Care and so on. In your view, were the existing pandemic influenza stockpiles of FFP3 masks at the start of the pandemic, were they adequate for the Welsh Government needs?
I think based on our experience, the supply set aside was inadequate for what we were seeing in respect of the coronavirus experience. So whilst they had been established for a pandemic flu, we were receiving something different. Nevertheless, the availability of the stocks alongside the central stores and, of course, local health board's own supplies meant that we were at least able to flexibly use PPE stocks available across Wales until we had been able to restore some more effective supplies.
And you set out that in Wales there was a dual-pronged approach to PPE procurement. There was the Four Nations basis, where the UK acted as the lead purchaser and led on behalf of the Four Nations. And then there was a Wales-only basis, where I think it was the NHS Shared Services Partnership in Wales were operating a separate procurement system. Is that correct?
That is correct, although we shifted more towards the use of the Wales approach through our experience in those early weeks in particular.
Can I ask how effective it was to have those two systems operating in parallel, and whether there are any difficulties with that? You said that you ended up moving more towards the Welsh system.
We were finding difficulties with the supply system being put in place at UK government level, of course for NHS England, because the procurement that was taking place was often buying up in bulk supply lines that meant that the NHS in Wales was sometimes not even able to access its normal supply routes as well. I think one useful example that I set out in my statement is of a company based in Wales that, whilst it always provided some residual stock to England, they suddenly had an approach which would have taken away all of the usual stock that we would have been drawing into our central stores in Wales. So there were very practical experiences. There were, however, some good examples where we were able to access some of the international supply lines through UK colleagues and working with the NHS in England as well. But ultimately, we decided that the best way of securing the national supply for Wales was reverting more to working through our Welsh National Shared Services arrangements in place, and we were very fortunate to have established a national organisation with this very specific role.
Can we look briefly at some of the concerns that were coming from the front line with healthcare workers who were using PPE and their concerns about the stocks and availability of PPE in Wales? I think you've been provided with the witness statement of Adam Morgan from the Wales Trade Union Congress, and he sets out in his witness statement that due to concerns about very low stocks of PPE in Wales, measures were taken in healthcare settings, including staff being told to be sparing with PPE, to reuse PPE, to purchase their own items that they could use as PPE, like using bin bags as aprons, and staff being encouraged to share single-use PPE. Is it correct that those concerns were brought to the attention of the Welsh Government in April of 2020?
Yes, that was correct. We had also had other views reflected on concerns on PPE. I remember the BMA, for example, who spoke to me as well as wrote to me at the time in March. So those frontline experiences and concerns were really important, and to respond to it, but also to be able to communicate about the availability of PPE as well.
Can I ask you then what steps the Welsh Government took in relation, in terms of addressing those concerns that were brought to their attention?
Well, when we were looking back at this in early March, which was when I recall having the concerns raised, it was one of the reasons to start using the countermeasure store, the pandemic flu stock, and that required ministerial authorisation, and we were able to get those out across the NHS in Wales, not just to hospital sites and distribution centres, but actually out to primary care and to GP surgeries. So it was really important that we showed that there were other stocks available beyond the local stores. We had a PPE cell established, and we're working through choices that we needed to make. We were trying to work on the supply chains that were available, but I think one of the most significant things was trying to give confidence about the availability of the supplies and the stocks that were available, both nationally, but of course more on a local basis as well. I thought there was some very good practice that was introduced by health boards that we adopted for all, which was communicating to their staff actually about the supplies, which would not be done on a normal basis, but were describing the number of days' supply that were available. And we also translated that at a national level to be describing that through both ministerial statements, but actually being asked those questions in press conferences, for example, where we were very open about the supplies that were available. So our role was to secure those national stocks, and we did so, but we had to share in a very salutary way at a national level and very publicly that we were down on some supply areas, even to a couple of days of supplies. I think gowns, at one point, we were down to only 2 days of supply left in our central stores across Wales, and then they were replenished within the following 24 hours.
Can we leave PPE there for now, please, and move on to steps to test patients and healthcare workers in hospital settings? And if we can look first of all at patient testing, I think on the 7th of April, the Welsh Government issued COVID-19 hospital discharge requirements. And although that was later updated, I think the initial guidance did not require the patient to be tested before discharging from hospital into a residential placement. I think it was on the 24th of April that requirement came into force. Is that correct?
Yes, the guidance on the 9th of April reflected the evidence of that time. And yes, it was updated on the 24th of April to make those changes to require a test before a discharge to a care home.
Do you know why it took until the 24th of April to make those changes?
I can't recall that it explains that in my statement. As I recall, we were always taking the very rapidly changing evidence at the time. Groups were working on that. We were trying to issue it into the NHS, out to our staff and to our hospital sites to make sure that they were aware of it. But I can't recall why there was a particular delay for it at that time, because our practice tended to be that we were trying to update the guidance as soon as we were aware of the changes as well. But
All right.
I can't recall the area in my statement that explains that.
Obviously, the concerns with or the necessity to test patients before they were discharged into a residential setting was clearly the concern that that patient might be infectious and then would go on to infect the people in that residential setting. Can I ask you this? Community hospitals are not mentioned in the discharge guidance or the letter setting out those changes of the 24th of April. Was there ever a discharge policy or guidance which required testing of hospital patients before they were discharged from an acute hospital into a community hospital?
I can't recall that because they would be within the local health board facilities. So patients typically would move across areas because that's the way in which we function. Somebody comes into an A&E department, they move to a ward, they move to the best location, safely, of course, for their care. I can check that for you, but I don't recall that there was different guidance. It was just part of the normal way of the NHS discharging its arrangements.
So that would mean, wouldn't it, that patients wouldn't be tested before they were moved from an acute hospital into a community hospital? Wasn't there the same risk of then causing an outbreak within the community hospital?
There's possibly the same risk. I would just have to go and check what those arrangements are. I just can't answer the specific question, I'm afraid, without checking that with other colleagues, and I don't recall it being in my statement either.
All right. Wales was, we have heard, behind England in relation to both the expansion of testing for asymptomatic healthcare workers and NHS patients. And again on the announcement in December of 2020 of routine testing of asymptomatic healthcare workers. What was the reason for the delays in Wales in relation to those testing policies?
The testing policies that were set out were always set in the context of the available test capacity that we had. So as we went through 2020, we obviously saw some very significant changes in the numbers of tests that were available that could be used for all of the different purposes, from diagnosis to surveillance through to those protective measures with our staff as well. If you look at the outset of the pandemic, back in March and April, we only had between 2,000 and 8,000 tests available on a weekly basis. By the time we got to December, those numbers of PCR tests that were available were as high as 130,000, for example, in a week. So you're suddenly at a very different position in terms of how you can use things.
Yes, if I can,
sorry, if I can
stop you there, Dr. Goodall. I wasn't asking why it took that long to be able to have a policy of testing routine testing of asymptomatic healthcare workers. I'm asking why there was a delay in Wales in comparison to when those policies were rolled out in England. Was there a specific reason why it took 6 weeks?
There was a reason at that time. So when England rolled out their asymptomatic testing, they were using LAMP technology, where they had laboratory systems that were in place to support them. From our perspective in Wales, and having had the advice that we wanted to revert to the asymptomatic side, if we had gone down the use of the same LAMP technology and accessed that through the national laboratories, we would have had to have set up and trained laboratory staff with those particular skills, and that would have had to have been dedicated, so that would have taken time. The game changer for us at that time, though, was the alternative opportunity to use lateral flow devices. They were still subject to some scientific assessment, but we were able, with that clarity, to confirm the start of the testing regime on the 4th of December 2020, and then we were able to start the rollout on the 14th of December.
All right, thank you very much. My lady, I don't know if that's an opportune moment.
Of course, yep. 11:32. Ms. Neal.
Dr. Goodall, if we can move on to a new topic, please. The shielding programme in Wales. The inquiry understands that the shielding programme was led by the Chief Medical Officer. And my questions to you are based on your oversight role, or your role in relation to those logistical issues which arose, rather than anything on the clinical side of that programme. You've set out within your witness statement that there were some problems with 13,000 of the initial 91,000 shielding letters going to the wrong address, being sent out to an old address, a previous address. I'd like to ask about some more issues with letters going to the wrong people, if I may, and particularly about the shielding letters that were sent to people with Down syndrome. I think the shielding patient list was updated to include adults with Down syndrome. And I think those that decision was made by the 4 nations' chief medical officers on the 30th of September 2020. It appears that the easy read letter for people in Wales with Down syndrome was drafted in November of 2020. I don't know that we need to go to that letter, but it's in draft form. Can you help us with why it took at least a month to send that letter out to those adults in Wales? I don't recall why there was a specific delay.
wanted to update the letters in the light of the clinical evidence and the agreements amongst the chief medical officers. I can't recall me explaining that in my statement, and I don't know if there were any specific reasons why that wasn't issued. My own view would be that it should have been issued when the chief medical officer changes were made, but I don't know why there was a delay.
Can we have a look at a letter that was sent to children or under 18s with Down syndrome? That's INQ 469066. This again it's an easy read letter. It's dated the 5th of January 2021, and it explains that it's correction to a letter of advice that had previously been issued. It doesn't explain when that letter was previously issued. Do you know whether when adults with Down syndrome were written to advise them to shield, whether children or those under 18 with Down syndrome were written to on the same occasion?
I don't know that.
All right, you maybe can't assist with that. But it appears that erroneously, children with Down syndrome should not have been added to the shielded patient list, but were written to and told that they were needing to shield. It may be that you don't know how that mistake occurred. Can you assist us with that?
The whole process of the shielding letters was a very technical and complex process. We had never done anything like this in Wales before, about the way in which we were linking a wide variety of databases that were available. There were so many technical processes to go through. We were having guidance that was changing. We were having to update it. Obviously, there were patients who were being diagnosed with conditions that fitted within the shielding criteria that changed from even the first issuing of those letters. So I just would want to describe that kind of context is there would have never been any intention to send an inappropriate letter or the wrong guidance, but it was often happening at pace, and it was very technically complex to keep on top of the changing arrangements of patients during that period of time. And I apologise if there was any impact of that, of course, but I hope by correcting that in January, we were at least able to make sure that the guidance was clear in terms of how shielding should be applied or not.
But you can't assist us with how long it was after the letters were sent out incorrectly to under 18s with Down syndrome that this correction was made?
I don't know. It would feel that there was a delay up until this point reading the letter. What I can say is when the original 13,000 letters had gone to previous addresses, that was addressed very immediately and they were sent out within a few days of that particular error at that time. But I can't respond on this very specific area, I'm afraid.
Perhaps we can move on then and look at the increased use of remote technology briefly in healthcare settings. And you've set out in your statement that the Welsh Government took a number of steps to encourage greater use of remote technology in healthcare settings, both in secondary care and in primary care using the Attend Anywhere platforms and through other means. The inquiry has heard that the increased use of remote technology has the potential to risk exacerbating inequalities for patients who may have struggled to access healthcare through those remote means. And we've heard about the digitally excluded. That's the terminology that's been used. Can I ask you this? Did the Welsh Government take any steps to address that potential risk of digital exclusion of some patients when they were encouraging the greater use of remote technology in healthcare?
Yes, there were steps taken. We already had extant policies for the use of technology in Wales that reflected on digital exclusion. And of course, that would mean that we were using that extant guidance and advice throughout this process as well. There is always a danger that when you are changing the way in which you organise our services, and this was done in an exceptional way at speed as well, that you still need to retain, of course, those other routes for patients as well. And we wouldn't have assumed that there would have been comprehensive coverage through these areas, but these were at least a way in which we could, at volume, have alternative ways in which patients could still be seen within the system as well. by the time through the pandemic experience we were in 2021, we were able to make sure, for example, that the digital strategy that was reissued was able to reflect on those areas and make sure that we were able to understand that not everyone would be able to access the digital technology that we were using as well. But it was there for professionals to use and was there in line with a general offer that people would have the right access to their services as well.
A new topic, please. Can we look at staffing issues within the NHS? And first of all, in terms of staff availability and the impact of staff absence for illness and other reasons. Your witness statement sets out that the Welsh Government requested information on staff absence from all NHS bodies from the 20th of April 2020. That was the first time that information had been requested, I think, on a daily basis. Is that right?
Yeah, requested on a daily basis, but we had certainly been using operational information from health boards before that time. I personally recall using it in some of my press conferences, for example, when I was talking about the NHS experiences. But it was the first time that we'd introduced it as a daily requirement, yes.
And is the importance of collecting staff absence rates on a daily basis, that gives an idea about the operational impact of that staff absence? So that particular unit is down by this many staff or this percentage of staff, and that affects how many patients can be seen and so on and so forth. Would that be correct?
Yes, that's absolutely the position. And there would be examples across Wales through that data where we would be seeing potentially even individual departments affected so that they were unable to carry out their functions, and would be a very salutary way in which you had this understanding of the impact on our staff across Wales.
So if that data was being presented as monthly absences, for example, we're not able to see the sort of day-to-day impact of those absences, is that right?
Yes, typically NHS Wales wouldn't have been looking at it on a daily basis. It was an exceptional introduction to track the experience of the pandemic.
And you explained that from the 9th of August 2020, that workforce absence data was collected once a week or fortnightly, depending on the COVID situation. Can I ask why that changed at that point from daily collection, given the information you've explained to us about the importance of knowing the daily picture?
I think at that time in the summer, we had seen a reduction in the COVID prevalence levels. We had hospitals across Wales reporting available capacity and lower numbers of COVID patients. It was an adjustment in respect of removing that requirement from the health organisations. They had it themselves, and obviously an opportunity to reintroduce it, which we did later, of course, when we were going into subsequent waves and seeing those pressures rise again. But it was just a moment where there was not the same level of pressure at that precise point during August 2020.
Can you help us with when daily data collection was reintroduced?
I can't recall, and I don't think it's set out in my statement when that was reintroduced again, but I recall using the sickness absence data very regularly myself. I can check that, of course, further to today's attendance.
We've also heard about returning NHS staff who've either retired or moved to work in different occupations, who were added to the temporary or emergency register to assist with the workforce during the pandemic. Did the Welsh Government obtain any data to identify how many of these registrants were in fact deployed or offered roles in the NHS in Wales?
We only had the overall position of those who had returned. We didn't have any of the local information in the manner in which they were deployed. And there were other staff as well that we were using in these figures. We were also using students, for example, within their educational placements who were also supporting us. So it was a wide variety of staff coming in through there. But we would be able to report the aggregate position, but not specifically where they were being used. That would be more a matter for the local health boards.
What I'm seeking to ascertain is whether the Welsh Government had any data on how many of the people who had effectively volunteered to come back and work in the NHS and had been added to the register ready to be deployed, how many of them were actually used, because we've heard there were some difficulties with people ready and willing to return to work in the NHS and never receiving a call that they had a place to go and work. So did the Welsh Government keep any data on that, or indeed on the students that you've mentioned?
I don't recall on the use. We set up those arrangements. We enabled it at national level. We made it available. But I would have to go and seek those figures as well. I know Jean would have reflected on some of those in her own evidence on the nursing side. But unless you can take me to a section of my statement, I don't recall that it's set out there in the detail that you're asking me for today.
No, I don't think that figure does appear there. So Welsh Government did, I think, have absence rate information from a TAC science evidence report in February 2023, which you cite in your witness statement at paragraphs 603 and 604. But if I can summarise it in this way, that report from February 2023 indicated that the average number of sick days per employee had remained consistent over the preceding 5 years, and that the leading reason for sickness absence amongst NHS staff was anxiety and stress, and that absence due to anxiety and stress had increased year on year. So the total number of staff absent had not increased, but there was a greater weighting towards stress and anxiety as the principal cause. Can I ask this, was there any national monitoring of staff mental health and well-being undertaken by the Welsh Government during the pandemic?
There was monitoring, and there were also actions that we put in place and enhanced. So there was a national scheme, for example, about support for health professionals that was run by Cardiff University. We ensured that was available. It had traditionally been available for doctors, but we expanded it to include a wider range of NHS staff. We were always working with the health boards to understand things that could help. I have to say that a lot of the mechanisms that were most supportive to staff to allow them to reflect on their experiences were overseen locally, whether they were through formal occupational health arrangements or whether they were just peer support mechanisms that were put in place. But there were some things that absolutely we could do at a national level, and we have continued to obviously monitor and support those areas. One of my outstanding concerns, given the extended period of time here, is that whilst we are through the pandemic experiences, we will still have staff who have experiences that are affecting them right now. And it's really important to be able to keep up those support mechanisms, both nationally and on a local basis.
You mentioned there that some of the most effective forms of support were provided by the local health boards. Can I ask you this? Did the Welsh Government undertake any review or evaluation of staff wellbeing programmes or staff support offers to identify what were the most effective means of support?
I would need to check directly, but I recall that our workforce group under our planning and response structures were working on those areas. They were helping us with some of the enhancements that we needed to agree, both ourselves and also with ministers as well. But I'd have to check the specific detail.
Thank you. Could we look, please, at the steps the Welsh Government took in relation to creating a risk assessment tool for NHS staff, or at least initially NHS staff? Can we go, please, to INQ 282020? This is a report of the Workforce Risk Assessment subgroup, which is a subgroup of the First Minister's Black and Minority Ethnic COVID-19 Advisory Group. Can we go, please, to page 23? Because this sets out a timeline of the development of the tool. And so we can see that the expert advisory group meetings began on the 29th of April. On the 1st of May, you, Dr. Goodall, endorsed the use of an existing risk assessment tool that had been developed by Aneurin Bevan University Health Board. So that was already in existence, is that right? And it was going to be used across Wales, or was that going to be used as the basis for the All Wales risk assessment?
This was an important area because the correspondence came in on the 19th of April. But even though we had commissioned the group to do the work and wanted to do it at pace, we just didn't want to have a delay, and we're aware of the work that an RM Bevan Health Board had done. So just in a very practical way, just wanted to make that available, roll it out and give all of the health boards and health organisations access to it, pending the production of a template. So I know that the group, of course, reflected on that template that did exist, but they also did their own work to produce a much better and more refined version as well. But it was more to ensure that there was no delay in terms of the support that could be provided.
All right. So we can see that on the 5th of May, the risk assessment subgroup first met and commenced its weekly meetings. And then on the 27th of May, the workforce risk assessment tool was made available as a PDF on the Welsh Government website for immediate use across the NHS and social care. Can you assist with why it was that the Welsh Government tasked this particular group, the Black and minority ethnic subgroup, with the development of the workforce risk assessment tool?
There was an opportunity because of the correspondence that had come in from Professor Singal on the 19th of April. We have close relationships with our clinical teams, with our groups and with our organisations in Wales, and Professor Singal had written to the First Minister. The First Minister was very clear on this, that he wanted the external support to be very visible. We were able to put in the relevant NHS support, as you would expect, and was very happy to be able to take up Professor Singal's offer to lead the work. And we were able to balance the NHS representation alongside some of the expertise that we had in Welsh Government and beyond it as well. But it did form part of wider arrangements that were put in place for Black, Asian and ethnic minority staff and people, and other work that the First Minister had commissioned as well. So I thought it was useful to have that as a package.
All right. Can we look briefly at the way that tool developed, or to perhaps contrast the initial tool as first published on the 27th of May with, at the time of this report, which was, I think, July of or June of 2021. So if we can have a look, please, at page 33. And if we can, thank you, if we can see the steps are set out there, that the first thing to do is to complete the risk assessment, understand the risk and identify the right actions for you. And we can see at the bottom that pregnant women may be particularly vulnerable and must not work in direct patient-facing roles beyond 28 weeks. And it says, important note, if you're of a Black, Asian, minority or ethnic background and under 28 weeks pregnant, new information indicates that they're at considerably increased risk throughout their pregnancy and should avoid face-to-face contact with COVID-19 cases. This means no frontline work where there is sustained community transmission. And if we can see page 34, please, this gives the scores for the risk assessment tool. And can we see step 1, please? The box that says confidential once completed. So here we see the risk factors are set out, and there, if you're aged between 50 to 59, 1 point, 60 to 69, 2 points, and over 69 doesn't appear on this initial iteration. But ethnicity, do you identify as one of the BAME or mixed race groups set out in a link? There is 1 point there, and then we also see there are 1 point for various comorbidities, obesity and family history. And can we come on then to look at what was then the current version on page 37, please? We can see that's the 29th of June 2021. If we can go over the page to page 38, please. Can we see at the bottom pregnancy? The advice has changed now. It says all pregnant women should undertake an individual risk assessment. This is because pregnant women may be particularly vulnerable. So the advice for pregnant women has changed. And if we can go on to page 39, please, and see the scores that are attributed for different risk factors. And if we can see the box in the lower half of that page, the risk factors, there's now included workers aged between 70 to 79, and they're ascribed 4 points if they're in that age bracket. So would you agree that failing to include that age range in the initial risk assessment was quite a significant omission?
Yes, I think clearly we knew that age was a factor on COVID. Of course, this was the work of the group, and we're very happy to take their advice on the amendments that need to be made. But as I look at your comparison, that would feel that that was an omission. I agree.
And we can see that on that page, there's a point for ethnicity still at that stage, and still the same comorbidities are set out, obesity and family history. Do you know at what point it was that those changes were made to include older members of the workforce?
I don't know. Those numbers would have been small across Wales over those age groups, but I don't recall the precise date. This work was done by an expert clinical group with our clinicians across Wales with workforce support, and they were left to develop it in line with the guidance and the evidence, and I thought they really did an excellent job pulling that together, and very quickly given the circumstances as well, but I don't recall precisely the date, I'm afraid.
Can you tell us this? Was it mandatory for the local health boards to ensure that all their staff or workers, whether they were employed or outsourced, was it mandatory for them to ensure that they undertook a risk assessment for all staff?
It wasn't mandatory, but this was issued to emphasise the importance of it, to make sure that people used it. Our overall numbers showed us that not all staff were subject to the review. We know that 71,000 staff out of around 100,000 NHS staff across Wales had the review done. We know there were 74,000 across public services that used it, because this version, despite its health context, was then used in other sectors as well as a helpful way of understanding risk assessments in other areas too.
Did the Welsh Government do anything to monitor the local health board's compliance? Did they do anything to check how many staff were being assessed?
It was left very much as a local operational matter for the health boards in line with their legal and statutory responsibilities.
All right. I think you've been provided with the statement of the medical director of University Hospital Wales. He sets out some concerns about the risk assessment tools, and particularly the lack of guidance accompanying the risk assessment tool. He says it was initially only available as a paper document, and then subsequently only on the ESR, which I think is the electronic staff record, is that right? Where it was not easily found. Had you been made aware of any of those issues with the accessibility of the risk assessment tool for staff?
I was aware of some of the early problems because it was being provided in a static way. We tried to, over time, use the electronic staff record, but we also wanted to make sure that if people just wanted to download a paper copy and use it, that was also appropriate as well. And there were 49,000 copies that were actually downloaded, which we would assume were used as part of that more practical approach as well.
All right, thank you. So finally, lessons learned and recommendations. You've explained to us that you moved from your role as Director General of the Health and Social Services Group in November 2021, and I think your successor in that role will be dealing with formal lessons learned and exercises undertaken by the Welsh Government. But I'd like to ask, if I may, for your personal reflections on the challenges that arose for the Welsh healthcare system in responding to the pandemic, and whether you can identify for the inquiry any areas of the pandemic response where you would seek to do things differently in a future pandemic?
It's very difficult, even when giving evidence or the range of statements that I've already done, to convey how it was and how it felt at the time. With the way in which this virus was developing at pace, the need to turn the way in which we organised the NHS upside down, and even approaching areas like being asked to double our capacity, which was something that had never been considered in any previous arrangements as well. And if I could just say on the record, I just thought our staff were extraordinary about the way in which they stepped up and responded to those. They were professional and they were committed, and I think that gave an awful lot of assurance to the public about their experiences as they went through this as well. I think there are learning aspects about that. Having mentioned staff, I do think that we need to ensure that when staff are in normal day-to-day business, they have the emotional support and counselling that is available to them. Often that can be delivered on a local basis, but I think we do have national responsibilities to ensure that that is in place. But it does need to be enhanced and targeted when you are going through such a sustained period of time. We're very used to dealing with major incidents that last for a very limited period of time, but not used to this experience of running through a sustained response that lasted ultimately over 2.5 years or so. I just wanted to recognise and thank, though, our staff for the way in which they did that and the sustained way in which they did it. On practical areas, there would be 3 areas that I would highlight, which I think would be useful to reflect on. The first one is, I think there is a real need to accept and validate contingencies. The NHS is often having to respond to being productive, efficient, value for money, and all of those are very appropriate. But sometimes there is simply a need to make available and invest in the contingency itself. You can argue that the level of supply that's been made available for PPE is an example of that. Certainly as we go into a future pandemic, the requirement to retain testing infrastructure and flexibility is really important, and to have available from day one. That is something that would have affected a number of the choices that we could make, and the tests that were available were a constraint on the system. But you need to invest and have that available. And the NHS is very used to always running hot, always using the available capacity, as you've seen in some of the figures you were sharing earlier on bed capacity, for example. And I do think that specifically in this, there is a need for us to ensure that we improve the critical care capacity that is available. We had started that before the pandemic, but the levels across the UK need to be raised if they are to be able to respond to a future pandemic that emerges, whether we are still needing to expand critical care in an extraordinary way. So a very practical recommendation for me is to make sure that we're able to expand critical care capacity and to make sure that that is available. My second point is that for understandable reasons, and this is right and proper, there is a lot of focus at the moment on recovering the backlog of the NHS experience. That's particularly reflected through waiting lists and waiting times. And I know that every area of the UK will make progress on reducing the waiting times that were created as a result of the pandemic, and will have their own plans in place. What I am concerned about is that we have learned through the pandemic about the impact of underlying health conditions and characteristics of our population. And I would say that in a very practical way, there needs to be a recovery plan for health that also forms part of those plans. Otherwise, we won't be ready for the next pandemic as well. And then my third point that I would reflect on, which would be on the back of my experience and enhanced through the pandemic, is the best support, guidance and direction we gave was when that was done collaboratively across Wales, with organisations, with hospitals, with frontline staff. They were always the best because they were reflecting their experiences, and they were informed by their experience and their expertise as well. And in the middle of all of the structures that we put in place, just recognising that that was a really significant thing that made a difference to us was our ability to do things together and in collaboration, which you would expect, of course, from the NHS on the one hand, but sometimes organisational boundaries can get in the way, and it's really important to recognise that we did something that was very exceptional in that capacity during the pandemic response. Thank you.
Thank you very much. I have no more questions for you, Dr. Goodall.
Thank you, Ms Neild. Mr Wagner.
Good afternoon, Dr. Goodall. I represent the Clinically Vulnerable Families, a group which advocates for the interests of the clinically vulnerable, the clinically extremely vulnerable, and their families. The first topic I want to ask you about, please, is IPC, infection prevention and control measures in healthcare settings. Do you agree, Dr. Goodall, that it was often necessary for clinically vulnerable patients to visit hospital in person more frequently than other non-clinically vulnerable patients?
Just because of their nature, yes, I would accept that they would have to have a contact with health services more frequently than the general population, for example.
And do you agree that by definition they were more at risk from COVID-19?
They were more at risk from COVID-19. It, of course, is one of the reasons why we introduced criteria in the shielding approach, for example, in Wales and the wider UK.
At paragraph 293 of your statement, you say that in November 2020, the nosocomial, that is hospital-acquired transmission group in Wales, found that hospital-acquired transmission was increasing in line with community transmission rates, that proper use of PPE in hospitals was limiting the spread between staff and patients, but that transmission was happening from patient to patient. Do you recall that finding and that reference in your statement?
I recall the finding, and I recall that part of my statement as well.
Given that those findings in November 2020, what steps were taken to provide additional protections for clinically vulnerable people?
The arrangements were put in place through the nosocomial transmission group, and the report that you were describing. Actually, a number of measures were set out that would make a difference to the general infection prevention and control arrangements within our individual hospitals and sites across Wales. We obviously, at this point, were still retaining shielding approaches, and they were there to guide a general approach. But of course, that would still mean that people could be exposed to the hospital environment. The general infection procedures that we had in place would have been expected to be there for all of our patients, including those who were the most vulnerable as well. But on a local basis, health boards were able to ensure that they were adhering to those policies and also ensuring that they were able to track patients who were needing to come into our facilities as well.
So you've spoken about general measures, but was anything specific done to put a ring of protection around the most vulnerable who would be at most at risk of COVID-19 if they caught it in a hospital?
We had put in the shielding mechanisms that allowed us to highlight those areas. Of course, we were trying to ensure that any patient coming into our facilities would feel that they were doing so and were safe, as well as ensuring that our staff were able to respond in that way. I don't recall anything specific, nor in my statement that says so, but the range of measures that were introduced, not least in that November 2020 report, would have been intended to show that there were further actions that could take place.
So the answer is no. There was nothing specific to that group done.
I don't recall anything specific. I could check, but I don't recall it at the time.
Thank you. In late October 2021, you were informed that nosocomial transmission rates remained particularly high between patients as opposed to between staff and patients, so the same issue. And that in Wales they were higher than Scotland and arguably higher than England. At that stage, in October 2021, almost a year later, was any particular action taken to put that ring of protection around clinically vulnerable patients because of their particular risk?
As I said earlier, the nosocomial transmission group was still reviewing experiences. There were further measures that the group had introduced from what had been kind of guidance role and monitoring. They had actually introduced support through their group mechanisms for outbreak management alongside Public Health Wales and others. But I don't recall anything specifically on the clinically vulnerable in the manner in which you've asked the question. So it would be no to the specific answer, but to the range of actions that were still in place, they were, of course, still being overseen by the nosocomial transmission group.
So no again. In hindsight, do you accept that given the particular risk to clinically vulnerable patients, it wasn't enough just to put in general measures more attention should have been put on putting that ring of protection around the clinically vulnerable, in particular in healthcare settings?
Yes, in hindsight, and given your questions, I would agree that they are a group who would have taken additional confidence and assurance about measures that were wrapped around them. I can't describe to you whether health boards, because they had access to the shielding list, did put in local measures because they were operationally responsible. But I do accept if we had made that clearer at a national level, then that would have helped with the confidence of people coming into our hospitals to have care.
Well, not just confidence, but also the safety.
Oh, safety and confidence, I agree, yes.
In September 2020, you advised that visitors to health and care facilities should wear face coverings, and that staff who provide direct clinical care of patients should wear FRSM masks, that is surgical masks. Do you recall that in September 2020?
I don't directly recall it, but I was sending out a lot of guidance as well, and that would be the kind of guidance that I would have issued. So I accept that happened in September.
Okay, well, for the inquiry's reference, it's INQ 000392008, but I don't think it needs to go up. Is it right that the reason staff providing clinical care were required to wear those FRSM masks rather than just face coverings was as an IPC measure, that is, to prevent the spread of COVID between staff and patients?
That would be one of the reasons for it. Obviously, clinicians would give advice and we would be in line with the UK guidance. But yes, that would be one of the reasons for wearing it.
Was any consideration given to asking patients to wear masks rather than face coverings, given the relative benefits of masking and the known risk to patients of the known risk of patient-to-patient spread of COVID-19 in hospitals?
I don't recall consideration. You would have to ask colleagues who were in the UK infection prevention control group, and I don't know whether that would have been reflected in our nosocomial transmission group arrangements, but we were always adhering to the guidance that was available. And I don't recall any guidance under consideration that was about providing that level of FFP3 masks to patients, for example.
Oh, I'm sorry, I was asking about FRSM masks at that point,
okay.
not FFP3. Does that change your answer or not?
But potentially, but I would still say we were issuing the guidance in line with the advice from the UK infection prevention control, and they were aligning it with the international evidence at the time as well.
Thank you. I want to move on to the shielding programme and how it was designed. You've highlighted an undated integrated impact assessment on the impact of shielding on vulnerable patients as an important review which was undertaken of the shielding programme. Do you recall that?
Yes, there was an integrated impact assessment that was done of the programme, and there was also one that was done of the food delivery process as well.
Do you agree that this involved an assessment of providing the support which was implemented, for example, food boxes, medicine deliveries, to those on the shielded list, rather than or instead of a full analysis of the impacts of shielding on the clinically extremely vulnerable, or any analysis of the appropriateness of the shielding measures selected?
I agree that what it wasn't doing was determining the level of impact, for example, on transmission of the virus and whether it had prevented that. It was about the practicalities and making sure that people who were asked to shield did not feel isolated in respect of the contact and certainly the delivery of the food boxes as you described.
Was any wider review undertaken of the shielding programme as a whole, including points like impact on the shielded, and the general appropriateness of the design of the programme?
There was some work that was done by Swansea University where they were looking at a wider range of issues and particularly trying to look if there was any evidence on the impact on the virus, but also allowed them to reflect on some of the experiences such as isolation as well.
But that review wasn't undertaken by your department or your government?
That wasn't, no.
No. Should such a review have been undertaken, given the very significant impacts of the shielding programme on a large number of people?
whilst we did those early reviews, and you are right, ultimately we were providing shielding advice to about 138,000 people. That would be useful to have some understanding of the shielding impact beyond those and be able to track it, certainly for future pandemics as well. And I hope that the inquiry will have a chance to give some reflections on that too, of course.
Will your government be doing any kind of review of that kind?
I've been out of the NHS role for 3 years on the shielding side. I'm not aware that there is a review being undertaken just through my permanent secretary experience, but I can certainly check on that.
Okay, thank you. Finally, I want to ask you about the clinically vulnerable. And when I refer to the clinically vulnerable, I'm not including within, I'm talking about the wider group that would also include the clinically extremely vulnerable, but the larger group of clinically vulnerable people. In a briefing note prepared for the First Minister on the 20th of March 2020, it said that after securing the needs of the shielding population, a team would work on phase 2, identifying wider vulnerable groups, and that the potential support could be that potential support could be then be provided to them. This is referred to in paragraph 728 of your statement. I think it gives the wrong date for the briefing. That wider group of clinically vulnerable people, although not formally shielded, were still provided with stringent advice to keep themselves safe. Are you aware of any steps that were taken to, or put in place to give additional support to that group rather than just generalised advice? For example, access to medication, avoiding public spaces, being able to explain their vulnerabilities to employers.
I know that when the chief medical officers were working through their criteria, there was a worry more generally about other people who, if exposed to the virus, would likely be more susceptible. I know that from our approach that we were doing back in March 2020, and we were speaking very rapidly to local authorities and also to the third sector across Wales, we did put a focus there that despite these particular individuals that we were putting arrangements in, that we did want there to be a wider understanding of others who would still be potentially exposed and would have to follow the guidance as well. But I can't directly respond to your question on the practicalities, but I do recall the third sector conversations, and I know that both officials and the sectors themselves wanted to make sure that as much support could be given as was possible, but the food boxes were only accessible for those who were in the higher level of clinical vulnerability.
CVF, the organisation I represent, are aware from its members that in practice many clinically vulnerable people informally shield to protect themselves due to the level of risk that they felt they were at, but without that statutory support. Did NHS Wales, as far as you're aware, make any effort to monitor that wider group of the clinically vulnerable and their response to the pandemic?
Not as far as I'm aware at the national level. Local health boards would have been more plugged into the local operational arrangements and the distribution that was happening, and they may well be able to give some evidence that would explain that better.
My final question. We know that a significant proportion of those who died or suffered adverse effects from COVID-19 were clinically vulnerable, but not clinically extremely vulnerable. Do you agree that a better understanding of the way they behaved and how they managed their risks could have informed the delivery and the design of more effective guidance and support for that wider group?
I agree. That would be additional information that would help us, and not just in respect to the experience we've been through, but in planning for a future pandemic as well.
Okay. Thank you.
Thank you, Mr Wagner. Ms McDermott.
Good afternoon, Dr Goodall. Today I'm asking questions on behalf of the UK COVID bereaved Families for Justice and the Northern Ireland COVID bereaved Families for Justice. My lady, if I may, I'm going to take the questions in reverse order to which they appear. Dr Goodall, in your statement of evidence, an initial section entitled Broad Overview and Reflections on the Health and Social Services Group and NHS Wales activities during the pandemic period, at paragraph 14, you talk about personal reflections And under that rubric, at subparagraph H, you state, it was an ongoing challenge to ensure the governance arrangements recognise the equal status of each of the four nations. And with the establishment of the UK Health and Social Security Agency, there was a concern that the forum in which the UK government engaged with the devolved nations was adjunct to the main decision-making mechanisms. Now, today you've already mentioned in your evidence this morning that there was a concern in the early stages that the early signs of planning for England having an impact on the supply lines for Wales, but you stated that that didn't really happen in practice, and so that's probably something different. My question, and I wish you to focus on this, is that in your statement, in your personal reflections, you specify the ongoing challenge to ensure that the governance arrangements recognise the equal status of the four nations. And so my question is this: can you give some specific examples of the challenges that you refer to?
Yes, so I think they were usefully laid out in the email that I was exchanging in March. So firstly, in respect of PPE distribution, with all of the positive and good intentions to make sure that there was a UK-wide supply line and internationally, the danger that in implementation that became more about responding to NHS England than it did about the respective NHS arrangements in Northern Ireland, Scotland and Wales. Of course, I was concerned for Wales, but I was in discussion with others. We were particularly concerned at the outset that the way in which ventilators may be distributed were going to be in line with the geographical transmission. And with it having started in the southeast and we were a few weeks behind, there was a genuine worry at the outset that the ventilators would go where initially needed rather than where needed over time. And by the time that you are ending up in the top left-hand corner of Wales, the reality that actually there is nothing left to support those populations, it was really important that we were able to articulate that. And as I said earlier, I did feel that in escalating these concerns, although they were happening practically, that we were able to work that through with colleagues more generally as well. And of course, as we generally make arrangements for the NHS, there is something about the way in which we understand the normal business of the NHS in operation as well. But there is, generally speaking, good contact across the NHS, and I deployed some of that to my advantage during the pandemic itself, of course.
That some point takes me to my next question in terms of the contact and communications. And I wonder, did you discuss the perception that you had with your counterparts in the devolved nations and whether or not there was any credibility or evidence giving rise to the concerns that the devolved nations and your counterparts may have had?
Yes, I was having discussions. We met regularly, and in particular during the first wave arrangements and the second wave arrangements as well. But yes, there were clearly procurement arrangements that have been put in place that were labelled as NHS England and protecting supplies for the NHS in England. And that wasn't just a worry or concern, it was the way in which suppliers were being engaged with as well. So that was the thing that we needed to keep an eye on for procurement reasons, but it did affect some of our later reflections as well.
And I suppose then taking you to moving forward and thinking about lessons learned, what was the impact of this issue and what lessons can be learned from it to draw forward and taking away perhaps a little bit from the direction towards NHS England?
Well, I think that when we are going into this again at a UK level, to be clear where we are making arrangements on behalf of the whole of the NHS, rather than just the structures that we have in place that separate NHS Scotland from NHS England and from Wales. I think that's really important for us to work through. What it created at the time was anxiety in a very rapidly moving position with modelling that was telling us about the level of beds that were going to need to be available, and a real worry and fear that we were not going to be able to accommodate the patients with the right equipment or consumables that we needed as well. So they were genuine concerns at that time, and there was fear at that stage. But I hope that in the relationships we had and with the contact we had, we were able to de-escalate those concerns pretty rapidly. But it was absolutely a worry in the middle of March to the end of March.
Thank you, Dr. Goodall. I want to take you to a different topic now, and it's in relation to the support for the bereaved families in Wales. In your statement, you refer and note to the National Nosocomial COVID-19 Programme Interim Learning Report, which was dated March 2023. And you rehearsed the key learning areas identified therein, which included bereaved support services, which should be proactively made available in Wales to all families. Now, in a final report, and I'm not going to take you to it, but for the reference for the inquiry, it's INQ 000501402. That report, the final report, was published in August 2024 and is obviously after you submitted your statement to the inquiry. Now, the final report identifies that bereavement services should be proactively signposted and offered to all families who are experiencing grief following the loss of a loved one. My question is this: how is the NHS in Wales ensuring that such support services are being proactively signposted and offered?
I think that question probably is better responded to right now by my successor, who obviously is giving evidence this afternoon. I've not been in the NHS role for 3 years. We did put in a bereavement strategy that was much clearer even during the pandemic in October 2021. I agree with the points that have come out of the learning report as well. It's really important that that very personal experience is provided. The NHS is a service of volume, but it always has to make sure that it is an individual experience going through it as well. And I think that we can absolutely improve the experiences for patients who are accessing our services. And I think that report will be very important in terms of the way forward for the NHS in Wales as well.
Very grateful, my lady. Those are my questions.
Thank you, Ms McDermott. Ms Gowman. Oh, there you are.
Doctor, I ask questions on behalf of COVID-bereaved Families for Justice Cymru. You told the Senedd in November 2020 that the NHS in Wales was, quote, stuck by the fabric of our hospital buildings and healthcare settings across Wales. You acknowledged at that time that the underlying issue of ventilation was a factor that still needed to be explored, and you were hopeful that more could be done. Why had there been a failure to improve the NHS estate in terms of upgrading hospitals to have better ventilation, and what was done immediately to improve ventilations in hospitals following your statement in November 2020 as Wales headed into the second wave?
The estate in Wales is very mixed, and we review the backlog of maintenance requirements. We also have health boards in Wales who come forward with their own local plans for how they wish to replace and improve local capacity. Sometimes that can improve new hospital builds. So one of the ways over the years in which we've been able to do that has been able to improve the hospital accommodation by new hospital builds. But our capital that is available to us every year, it's about 300 million a year, is quite limited in its ability to do that at pace and scale across Wales. So ultimately, some of the choices that have been made both by health boards and by Welsh Government in support of their decisions would have been constrained by the available funding and finances as well. And I think that will continue to be a problem into the future. On the evidence itself, in respect of ventilation, we did have expectations that health boards had to do the best they could within their available facilities. I know the evidence that Professor Klur gave yesterday was very powerful in terms of giving an operational insight to what that meant. But there would have been some real constraints for ventilation, particularly during the winter months, for some of our oldest and ageing estates in Wales that were decades old. So that would have been problematic. On the ventilation side, whilst health boards would have had that individual and operational responsibility, we did have an estates infrastructure group. We also had other planning and response mechanisms that were available to work through this guidance. And by this point, we also had the nosocomial transmission group that was in place because we had introduced that in May 2020. But I can't, unless it's clear and available in my statement, put my hand on something that says precisely what happened after November 2020. I'm sorry.
And to follow on from that point, the National Nosocomial End of Programme Learning Report that we've heard about, this was a programme designed to support the NHS Wales organisations to conduct investigations into patient safety incidents of nosocomial COVID, and that was published in August 2024. And we can see in that End of Programme Learning Report that issues pertaining to the NHS estate in fact persisted throughout the pandemic. Does that not suggest that insufficient steps were taken to mitigate the concerns relating to the NHS estate, despite the fact that you had raised those concerns in November 2020?
It may suggest that, I agree, but it may also, in a very practical way, show the difficulties of individual hospital sites complying with those ventilation requirements, just because of the physical nature of their estate as well. And some of the things that would have changed those would not have been possible during the pandemic response. Equally, some of the answer to some of those older buildings may well just be addressed by, for example, building a new hospital.
Yeah.
So, and that would not have been something that was possible during the pandemic response either.
But it was important, I'd imagine you accept, to recognise the limitation, to appropriately risk assess and to put in place whatever measures could be put in place in light of the limitations around the infrastructure. Do you agree?
I agree. That would have been an expectation, and operationally we would have expected health boards to put in a whole range of infection control measures to mitigate, but to do it on the basis of the wards and the buildings and facilities that they had. That's why we couldn't control that at a national level. It had to reflect the local insight and experience.
But you're not aware of any national oversight in respect of holding health boards accountable for what they were doing on the ground?
Through the group mechanisms that I gave you, through the planning and response cell arrangements which had health board representation, and as I said, there was an estates infrastructure group that usefully had been dealing with a number of the areas, including the original issues around oxygen supply, for example, and that was retained through the pandemic response as well.
Staying with the end of programme learning report, do you accept that the report fails to deal with key issues? For example, it fails to investigate causes for cluster outbreaks on wards and the closure of primary and emergency care services due to cluster outbreaks.
It may not have been the purpose of that report, but I agree that they are described as not being handled and dealt with, but that of itself would be useful information still to find, even if it's through a different mechanism.
Finally, on nosocomial transmission, many of our members witnessed healthcare workers failing to adhere to IPC guidance with regards to PPE. This is also recognised by Steve Ham, the Chief Executive of Velindre University NHS Trust, who discusses in his statement what he's called compliance/complacency fatigue amongst staff. What measures were taken at national level to ensure that the NHS health boards and trusts were properly enforcing the use of PPE by healthcare workers?
Well, firstly, to make sure that the national guidance was provided, the PPE guidance was always issued at a UK level and, of course, then transmitted and communicated within our Welsh structures. So just important that we were able to do that very regularly. Secondly, to learn from outbreaks that occurred initially in the first months of our experience. Public Health Wales had a very prominent role on that. Later, even though Public Health Wales continued to give that support, we used the nosocomial transmission group for doing that. And the reports that the nosocomial group produced, including those attached in my statement, we spoke earlier about the November 2020 guidance. That was itself clear that we still had concerns about some of the adherence of staff, particularly in areas that were in non-clinical areas rather than in the clinical areas themselves. So we focused on that. We met with unions, we met with our partnership forum, and we tried to make sure that as much support nationally was available on that guidance. But ultimately, that became a matter for health boards operationally to deliver and for them to work with their staff, of course, to wear the appropriate PPE, as I would expect myself.
Thank you, Doctor. My next topic is capacity, and you've touched upon this at length in questions from the CTI. But just picking up on a couple of points, your evidence has touched upon the fact that there were patients who may, under normal circumstances, have gone to critical care, but instead were cared for elsewhere in hospital. On various hospital wards. The intensive care expert, Professor Summer, gave evidence as to the importance of care being delivered on a critical care unit due to factors such as staffing ratios and the experience and qualifications of the care providers. Do you agree that patients in Wales who were critically ill but managed outside of critical care were put at risk?
Anybody who was not in the normal critical care environment may have been exposed to risk. I'm not aware of any experiences that were described where that was the case through the health boards or that were brought to my attention. But clearly, with the really exceptional arrangements we put in place to go beyond our historical capacity of 152, it's a very different experience to be caring for somebody with a normal nursing ratio in a critical care ward than it is in a theatre that has been set aside that can be used, that is providing good quality care, but outside of that environment as well. I think it's important to recognise, and this is not for invasive ventilation, there were patients who were able to be cared for in a different way with some of our respiratory wards and supported the use of CPAP machines as we learned about that treatment. But I do agree with the basic point, which is we would wish to retain as many patients as possible in a traditional critical care unit environment, even if that unit is expanding.
And similarly, the inquiry has heard evidence on the importance of staffing ratios in critical care, and that critical care capacity is not simply a question of available beds. The evidence of Jean White was that staffing ratios were diluted in Wales, and this was particularly acute during the second wave. Do you agree that that in itself demonstrates that the critical care capacity in Wales was stretched?
Well, bluntly, I would say the critical care capacity in Wales was stretched. I agree, and not just because of the ratios, but because of the exceptional efforts of the staff and the way in which they were being asked to manage these patients. But the staffing arrangements were really important. We were looking to expand based on the pressures that we were experiencing. I know Jean in her evidence also commented at the moments when we were concerned about some of those nursing ratios and actually introduced national guidance to step back from some of the more extreme ratios that may have been used but were never used in Wales.
And finally, on this point, and drawing together the consequences of that stretching, IFF research that the inquiry has received demonstrates that healthcare workers felt pressured to make decisions about critical care. This is supported by expert evidence which has been given to the inquiry that clinicians were likely making conscious and unconscious decisions on the ground not to escalate to critical care in times of stretched capacity and resources. Did your analysis as to the saturation of critical care in Wales consider or take into account that clinicians might have been making different decisions about escalation of treatment than they would have been in peacetime?
It would be easier to receive that as direct evidence from the clinicians concerned. I know that was one of the worries about our moral and ethical group, which was reviewing the criteria that we wanted to apply. Certainly, wherever a critical care bed was asked for, and when it was beyond the capacity of a critical care department itself, the advice I received was that we were always able to accommodate those patients. But you are right that clinicians can make individual decisions based on the pressures that a hospital site, for example, is under. And we were under very significant pressures during the first wave, particularly in April, and we were under highly significant pressure in the second wave, particularly in December, and as I remember it, in a very difficult place in January 2021.
If the potential for conscious or unconscious decision-making and the impact of that on escalation of treatment was something that was a concern of the ethical group, what did the ethical group do about it to mitigate those risks?
I don't know. I would have to check on that on an ongoing basis. They were issuing support and guidance into it at that stage and looking to give support. I know that the technical advice group also produced some supporting information for our workforce in Wales, basically on the judgments and the risks that they were being exposed to. And I haven't got it to hand, but I'm very happy to give that reference to the inquiry because it was a way in recognising that personal impact on clinicians making decisions as well.
Thank you, Doctor. Moving on to the use of field hospitals. You say in your statement that the use of field hospitals was limited and that this was one indicator of what you deem to be the success of measures taken by the Welsh Government. You gave evidence during Module 2B that the decision to discharge patients into care homes without a COVID-19 test was a ministerial decision intended to, quote, help the NHS create capacity. Why didn't you free up capacity by discharging vulnerable people into step-down facilities as opposed to care homes? Couldn't the use of field hospitals have served that purpose?
So firstly, the advice was about expediting discharge more generally rather than only to a care home environment. Many of the patients who were discharged were actually discharged to a home environment and with support. In March, when that guidance was being issued, and even in April, we were still developing plans that we could rely on for field hospital use. Some of the beds that were being extended and made available during April weren't directly in field hospital facilities. So at that stage, we weren't able to use the field hospital facilities because they were still under construction in most of the health board areas, as I recall.
Is this something that happened subsequently then? Field hospitals as step-down facilities?
Well, field hospitals were used as step-down facilities for individuals who had been through a COVID pathway. I think one or two of the health boards may have used them for general step-down when they were under more pressure, but they were never used for the acute receipt of patients. And the model that we developed in Wales was always about trying to deal with patients once they were ready to move to that alternative environment as well.
And in a similar vein, and you've been asked about the report in November 2020, it was recognised at that point that nosocomial transmission in Wales had increased, a number of concerns regarding implementation of IPC measures in hospitals, and a lack of available space to create low-risk or green sites in the Welsh hospitals. Again, why weren't the field hospitals used to mitigate against those challenges?
The field hospitals were temporary facilities. They were set up as a contingency to be available. We had other capacity available within our hospitals to use at that time, and even during November into December 2020, there was still available capacity within our hospital systems. We did allow health boards, of course, to make some of their own decisions about those areas, but due to their temporary nature, for general patients, there would have been some limitations on their use. They were always there as an ultimate contingency because we had wanted, if we'd seen the modelled levels coming through, make sure that every patient, whatever the workforce practicalities we needed to put in place, would at least be accommodated in a bed. So I just think it was for a different purpose, and in that autumn period, we still needed to retain the field hospital flexibility because we were seeing the numbers rise again.
Isn't another interpretation of field hospitals being underutilised, that the resources were not being exploited to their full extent rather than they were not needed?
I would say that the reason that we didn't use field hospitals as originally intended was because we were able to have confidence in the lockdown measures that occurred when that was announced in the last week of March, that we started to see the change in the transmission across Wales. If lockdown hadn't happened, the field hospitals could well have been in use, and we may well have ended up seeing scenes that were similar to those that we were seeing from Italy, for example, and other European countries. And we had wanted to mitigate that. Because we had never locked down the whole of our society, we wouldn't have had the confidence that we were going to see that kind of impact. And that's why we needed to have that preparation available. For future, I hope we would have learned an awful lot more in a different pandemic about using available capacity in a different way, the field hospital model and how it could be used. And I know our clinicians would have their own views on whether they could be used for other alternative mechanisms as well.
And moving on to my final topic, access to GP services. At paragraph 738 of your witness statement, you state that you were not aware of any specific difficulties with patients using the video consultation service that was rolled out to all GP practices in Wales. Many of our members reported GPs being hard to get hold of and not offering virtual appointments when they should have been, and these concerns were widely reported in the press up to as late as September 2021. In addition, the Public Services Ombudsman for Wales raised several issues with GP services in Wales, including a failure to provide virtual appointments for vulnerable individuals and service failures in lack of face-to-face appointments. With those comments in mind, do you agree that given that there were clear difficulties with the services, that these were issues that you should have been aware of?
They were issues that we were made aware of in the way in which you said. The operational use of the systems were for every individual GP practice. They were supported. by their health boards to implement that. We wanted to make sure that the platform was available at a national level to give that flexibility. Primary care was an essential service, and it was really important that it was kept open throughout the pandemic. I do know of moments when GPs themselves had problems either with their branch surgeries or, in fact, with an individual surgery being unable to open because of staff off sick with COVID, for example. But I believe that the technology should be used, but I think there should also be a route for patients to access the face-to-face when it's required also.
And finally, we know that no formal impact assessment was undertaken for digital inclusion, and considerations of recommendations on the elderly, disabled and those with language or digital access issues were not always explicit in the submission of advice or recommendations to the Minister for Health and Social Services. Given that these were considerations that had been part of Wales's strategy for digital health since as long ago as 2015, shouldn't they have been easily identified? Shouldn't they have been at the front and centre of advice to ministers?
Yes, they should have. You're right, the previous strategies were there. We also incorporated that in the revised digital strategy in 2021. Also, in those early weeks and months, we were moving so rapidly on a range of different areas that some of those impact assessments were not done as we would wish, but we were able to ensure as we went through the pandemic that those were discharged as we went forward. And as I said earlier, the concerns on the exclusion areas, digital exclusion in particular, I hope that we were able to ensure that at least that the platform was available, but there were other operational routes for patients to have access as well.
Thank you, Doctor. Those are my questions. Thank you, my lady.
Thank you very much, Ms Gowan. Very grateful. That completes the questions we have for you, Dr Goodall. I apologise again for having to bring you from yesterday to today, and also obviously for the imposition that the inquiry makes upon you and your department and all your colleagues. So thank you very much for your help. And I promise to make sure we get through Ms Paget's evidence today so she doesn't get adjourned overnight.
Okay, thank you, my lady.
Thank you. Very well, I shall return at 1:45.